Thank you so much for that kind introduction. And of course, I know Michelle is not here, but she's a dear colleague, and she has been many a time that second opinion that I've needed to guide me through complex cases in pregnancy and hematologic disorders. So we were very lucky to have her. And of course, I always learn something when I listen to her speak. I'll be talking today about an area that I'm really, really passionate about. And it actually affects more women than not. 80% of my patients as a hematologist are females. It's iron deficiency. And in particular, the theme of the night is supplements, products, infusions. So I'll be going into that a little bit. And I did want to acknowledge that I'm joining you today from Ottawa, from the traditional lands of the Anishinaabe people and the unceded territory. And it is a lovely day in Ottawa today, and I'm glad to be joining you tonight. These are my disclosures. So tonight I'll be talking to you about what are the symptoms of iron deficiency and iron deficiency anemia. And there's some that are going to be pretty obvious to many in this audience tonight, but some that might not be so obvious. So I'd like to go through that a little bit. Speaking of advocacy, if you think you have any of these symptoms, or any of your colleagues or any of your family members have any of these symptoms, what are you going to do next to advocate for yourself? And that's going to be a few simple blood tests and some products. We're going to talk about iron supplements and what to do if iron supplements don't really work in you. 30% of patients just do not tolerate iron supplements. What do you do next? And how do we go about avoiding blood transfusions? Well, blood transfusions are quite life-saving in certain situations. If you're a stable iron deficient anemic patient without active hemorrhage, you actually are worse off getting a blood transfusion. And sometimes in smaller centers, that's what's offered to you. And I just want you to know that there are other options out there. So what is anemia? So anemia is when the red blood cells in the body are decreased. And when the body doesn't have enough red cells, oxygen, which the red cells carry, doesn't get to critical organs like the brain. Some people describe a bit of a foggy brain, and they can't get to the heart. And in older patients that have anemia, not getting enough oxygen to the heart can lead to really critical heart attacks, even strokes. So it's really important to think about anemia as a problem with red blood cells. And the most common element, the most common component of a red cell that we really think about is iron. And that's why iron and anemia are so linked. And when that happens, that's called iron deficiency anemia. What are the symptoms? So there are the obvious ones. You feel foggy brain, you feel really tired, you might get palpitations. But there are some less obvious ones, such as mouth changes. You could get little cracks around the mouth or an inflamed tongue. You could look really pale and have a thing called pica, where you really want to crunch ice or have crunchy substances. You can get hair loss. I have a number of dermatologists that send me patients saying, my patient has hair loss. I can't deal with it unless their underlying iron issue is corrected first. People get dizziness, headaches, reduced appetite. You can even get a thing called restless leg syndrome when your iron levels are low. Iron deficiency affects over 1 billion people. Iron deficiency anemia, that is. And when you have just your plain iron deficiency, you can sometimes not be on the verge of anemia yet. Your stores of iron, just plain old iron deficiency may happen. That affects twice as many people. And dollars to donuts, I'm speaking to people in the audience tonight that are low in iron. I can pretty much guarantee that. So how do we get low iron? Biggest issue in my population, 80% of my patients are female, is menstrual losses. And more often than not, it may be heavy menstrual losses. There could be other issues too, such as pregnancy. It takes a lot of iron to make a baby because you're eating for three, really, if you think about it. You're eating for you, baby, all of those need iron. And then the placenta, 3. So you're actually trying to get iron for 3 entities when you're pregnant. So people become iron deficient in pregnancy too, for women. There could be inadequate dietary intake or reduced absorption, especially if you've had something called a gastric bypass surgery or you've got Crohn's disease. So all of those things lead to low iron. And in this particular audience that I'm talking to that may be affected by heavy menstrual bleeding, 63% of patients with heavy menstrual bleeding are iron deficient. So thank you again to Natalie and Amy for thinking about including me in today's discussion, because this is an important product, an adjunct product to think about, and that's iron supplementation. If you think you have these symptoms, you can talk about it with your family doctor. You can ask them for some blood tests. There's 2 blood tests you would need to ask your family doctor for: a CBC, or a complete blood count, which measures your hemoglobin, and an iron test. And those are just simple blood tests from the arm. And that's a ferritin level or a transferrin saturation. If you think you have these symptoms, ask your family doctor for the tests. And some folks can even get their lab values online. And you can ask your family doctor or your hematologist to interpret those levels for you. And if you think you're symptomatic, your next step will want to be asking about iron supplements. So some people say, well, can't I just eat a lot of iron in my diet? And I think that's really good when you're talking about prevention. And when you're not anemic yet, that prevention piece is really key. A typical diet does contain about 10 milligrams of iron per day. But if you're a female with menstruation, you probably need at least 18 milligrams of iron a day. And if you're pregnant, you need 27 milligrams of iron a day. And that's quite a bit of iron. And how do you get there? And this is prevention now. You can get there through vegetables and non-vegetable products. And as much as I'd like to avoid red meat, I do hate to say it, but heme iron, or the iron that's in meat, is actually better absorbed. 40% of that's absorbed from the red meat, the fish, the poultry. Now, that's not to say if you're a vegetarian, you can't be proactive and prevent iron deficiency that way through vegetable sources, things like legumes, seeds, tofu, and eggs. But the body absorbs only 10% of that type of iron. And that type of iron, or non-heme iron, is also affected by medications, osteoporosis pills, pills that prevent heart acid production, tea, dairy products. Those things actually affect the absorption of these non-heme iron. What can increase the absorption is vitamin C, although it may not increase it as much as we think, based on a recent study. You can take a multivitamin, but as long as it has at least 20 milligrams of elemental iron, you may be doing a good job with prevention that way. Actually treating, though, frank iron deficiency sometimes needs more than food. And when you get really iron deficient, either you let your blood tests go for a while, you let the symptoms go on for a while, and you just haven't gone to the lab, or with COVID, the lab just wasn't open for you to book the appointment. Sometimes people tip over the edge and become, quite frankly, anemic. Their hemoglobin becomes low. And when that happens, more than diet is required in that context. Then we're thinking about oral iron supplements, intravenous iron, and the very, very last thing, unless you're actively feeling lightheaded or dizzy, really dizzy, then a blood transfusion would be in order, but that's our last option, I would say. We try to do everything but. And when we're talking about oral iron supplements, you can go to the drugstore and see a mass of them. They're over behind the counter, not over the counter. They're not prescription per se, all of them, but they're behind the counter. And when you look behind the counter, you'll see masses and masses and masses of them at your local drugstore. And sometimes your family doctor, your prescribing doctor hasn't given you any indication what type of oral iron to pick up. And you just go with the pharmacist's recommendation. And what the pharmacist may recommend may be expensive, or it may be inexpensive. And you're going to have to let them know your budget. If you're thinking you're on a little bit of a tighter budget, and these products, by the way, in the inexpensive category, paradoxically are more effective than the expensive ones, if you can believe it. However, they are quite harsh on the stomach sometimes. The products that we're talking about that you may see are ferrous gluconate, sulfate, and fumarate. And they're the iron salts, and they're relatively inexpensive. And by that, I mean about $10 a month. And you take 1 or 2 tablets, sometimes every day, and sometimes every other day. And that can help resolve your iron deficiency. And most people need them for about 3 months. There are the more expensive kinds, such as Ferromax, which is $40 a month, or polyride iron. And then there's the other types of iron that are based from meat. So if you're a strict vegetarian, these probably wouldn't be for you. They actually are quite expensive. So I kind of leave them maybe not so much as the first line. They're Proferrin, Optifer, and Hemofort. And when you're taking iron, the unfortunate side effect is sometimes gut grief. Oral iron can cause constipation. And if that's happening, just make sure that you're taking it maybe to start every other day, getting really good hydration, because what the iron does is suck out all the hydration from your bowel, and you can become really constipated. You can get dark stools with oral iron, so just be aware of that. Taking a little bit of vitamin C, a tablet of vitamin C along with your iron can help. Spacing your other medications by about an hour can help. And if you're really getting constipated despite all the hydration, you may want to take a laxative concurrently with that. And compliance. So some people like me just forget to take their pills. I'm supposed to take my thyroid pill every day, and I sometimes forget, and I have, there's times I take 2 because I just literally don't remember. And then there's times I take 0. So I bought myself a pill dispenser. And when I looked in the clinical trials, there actually was a trial that was positive for people that put their iron in a pill dispenser. It actually helped increase their compliance. And they're about $2 or $3 the pill dispensers at Shoppers Drug Mart or your local pharmacy. So a typical algorithm that clinicians follow is try the oral iron salts first. They're inexpensive. They can cause some side effects, but try them first, especially if your patient is quite stable. If they don't like it every day, try every other day and recheck that hemoglobin level. Is that patient still anemic after 2 to 4 weeks? Are they tolerating it? These are important questions your doctor should be asking you. And if your hemoglobin goes up by a certain amount, and remember, we wanted it around 120 for your hemoglobin. And if it goes up and up and up and up, and your iron's good and your ferritin stores are good after that, then you can just continue on oral iron, and then you can work with a doctor like Dr. Schulzberg with the tranexamic acid. You may have a gynecologist involved that may offer an IUD to deal with periods, a birth control pill. There's lots of options out there. Because just as important as it is to talk about iron supplements, it's equally important to talk about what you're going to do to control the underlying bleeding. That'll help you with your quality of life and improve your iron stores overall. And if you're not tolerant of the oral iron, there's an underused product called intravenous iron. And this is how I think I met Natalie, is because I found that such barriers to getting this intravenous iron. There were clinical barriers. I'm from Ontario. There were administrative barriers. There were financial barriers. So I started a group with other hematologists to try to get rid of those barriers and to try to advocate, especially for women, to get access to intravenous iron. And there's a number of intravenous iron products, and they've been around since 1932. But if you ask women and you tell them, if you're not tolerating iron pills, that you can get things through an intravenous, most of them have never heard that. And there's a newer product around. It's been available for past 2 years at our hospital just in the past year, called Monoferric, which actually looks at giving an infusion, just one, to try to correct your iron deficiency in sort of one sitting. But the big iron products that are available, and some of you may know them and some of you may not, and I won't spend too much time on this slide because it's a bit more technical, but more the information is that there are IV iron products out there called Vinifer, ferrolicet, and monoferric, and some are lower dose and some are higher dose. And most women who have significant iron deficiency need around 1,000 milligrams of iron to be corrected. And how can you do that? Well, you can give 5 treatments of 200 of one type of product called Vinifer, all the way to if you just have 1 dose of the newer product, the monoferric. And at my hospital, we're allowed to give both. And so with the pandemic, we ended up giving a lot of the last line when people just wanted to come in once, get screened once, find parking once, all that hassle sometimes of getting IV iron. And I'll go into some of the logistical issues of getting IV iron. We ended up using a lot of the last product. Now, if you didn't want to do intravenous iron, there's some other interesting ways to correct that 1,000 milligram deficit. You could eat 500 steak dinners, but I think between the prices of meat going up and just the logistics of that, that would take you over a year. Or you could have 5.5 months of treatment. And if you're not in a rush and you'd rather not go to the hospital to get intravenous iron, and you're stable, you're not too symptomatic, you've got a mild anemia, you're taking and tolerating the pills well, you can do an oral iron tablet every day. There are some risks with intravenous iron. If you're in first trimester of pregnancy, we try to avoid it. If you're on antibiotics at the same time, we try not to give intravenous iron in that context. You do need to spend a little time at an infusion clinic, either at a hospital or an infusion center. And that often involves parking, finding childcare, taking some time off work potentially to put the intravenous into the arm. It's done by expert nurses usually. And then there are the additional requirements of, does your hospital cover it, or do you have to pay? And 1,000 milligrams of IV iron, if you were to pay out of pocket, is $450. And this is where the advocacy piece comes in. If you don't have a drug plan, that's going to potentially come out of your own pocket if your physician isn't an advocate or doesn't know the so-called ways around the system to try to get that funded for you. You may have to pay out of pocket, and that is really not, I think, an appropriate course of action. And we've been doing letter writing. We've been meeting with people from the Ministry of Health in Ontario to try to remedy some of those issues. There are other side effects of IV iron to think about. There's only a less than 1 in 250,000 chance you'll get an allergic reaction. But sometimes the intravenous can go into the arm. That's called extravasation. Sometimes the staff doesn't know too much about IV iron, even though we do train them. There's newer staff that are a little bit uneasy about it. Some folks can get some tightness in their chest. And eventually, after 24 hours, some people get a flu-like syndrome where they feel like they've got sort of a flu, but they don't. They just have, the body's just using the iron and it's settling in, and it goes away after 24 to 48 hours. And some people get low phosphate, but that's extremely rare. We haven't seen a case yet. So I just wanted to leave this a few items with you, because Dr. Schulzberg is very passionate about advocacy, as am I, in particular advocacy to IV iron. This issue disproportionately affects women and people of lower socioeconomic status, because without a drug plan or working conditions, they don't often have access to this product. In Ontario, we have a lot of funding barriers. So if you think that you yourself have experienced this type of issue where you're not able to access IV iron, or you know people, if you want to consider writing to your local MPP, the CEO of your hospital, fortunately our hospital has a drug coordinator who is able to navigate with our clinicians pretty effectively. But that's not necessarily the case at every hospital. And if that's the case at your hospital, consider writing to your CEO and bring this up with them. I just wanted to leave you with a few take-home points, and I'd be happy to answer questions soon. And if there's no questions right now, or you think of something later, I know Natalie would be pleased to take her questions and answer, and I'd be happy to answer them sometime later. Recognition is key. So especially in women with heavy menstrual bleeding, 60% of will have iron deficiency. And just don't ascribe it to, oh, I'm feeling a little bit, and it may still be the case though, oh, I'm feeling a little bit glum or a little bit, meh because of the pandemic. You could still have significant medical issue driving your feelings of lethargy, fatigue. And it's important to understand that if you are a woman with heavy menstrual bleeding, this is a concurrent issue to think about. Ask your doctor to check your hemoglobin and iron levels if they haven't done so already. And if you're found to be low, you can try oral iron supplements. And if they don't work, really try to advocate for intravenous iron. And every hospital is going to put in a bunch of roadblocks for women to get this IV iron. And I'm really hoping these roadblocks are little by little being dismantled. As the last thing we want our patients to do is to get red blood cell transfusions. We'll give it if they need to, but that is really our last resort. There are some interesting resources. So the Dietitians of Canada have created some dietary resources if you're in that prevention side of things where you're not quite anemic. You can read about foods that are rich in iron that may help stave off iron deficiency. Dr. Scholzberg has mentioned here lots of resources around the period website, but I really like her Iron Mom website that has a lot of patient-facing, interesting material. And the Ontario midwives as well have a lot of interesting material about iron supplements, and I find that it summarizes things nicely too. And of course, I'd be happy to take any questions at this point. And if people are shy, sometimes people are a bit shy, feel free to I'll answer them later. No problem.